OSA and metabolic disorders, whether it is a chicken or egg situation, what comes first? So let me take you through a case, a 38-year-old primary gravid. I saw this lady at Vadia Maternity Hospital where I am attached. I'm basically MD medicine consulting physician, so I deal with obstetric medicine also. This lady is IVF conception patient with a pregnant lady, 24 weeks of gestation. I was calling because her blood pressure was uncontrolled, she had headache. She was also recently diagnosed to have GDM. So basically that high blood pressure, she got admitted at 24 weeks. When I went and saw and inquired, she on taking the sleep history specifically, she complained of sleep fragmentation. I am not able to sleep for almost last 1 month, she said. And also she agreed to have a frequent urination at night, nocturia. She had agreed to have mild snoring in the pre-pregnant state, and which has increased now during the pregnancy. On taking the parents' history, her mother also used to snore, so snoring was considered as a part of very routine thing. When her husband, I asked him, he agreed that she does choke sometimes in sleep, and during the day she tends to feel dizzy, she feels fatigued, and prefers to sleep in the afternoon. She has a habit of taking at least 4 cups of coffee during a given day. Her weight in the pre-pregnant state when she was undergoing the IVF treatment was 72 kilos, and now it has increased to 78 kilos. Her height is 155 centimeters. Her blood pressure at that moment when I saw it was 160/100. She was admitted with even higher blood pressure. Some antihypertensive drugs were already started like labetalol. She did have edema feet, and when I saw her, she definitely had a short neck, and which was having a circumference of 42 centimeters. So this case now, with the background of OSA learning that we have had till now, I think is a very straightforward diagnosis, isn't it? Do you all agree that she is likely to have sleep apnea, OSA?
Yes.
Yeah. So, but she has some additional features also, not only sleep apnea. She is an obese lady. She's 72 kilos even pre-pregnancy. She has short neck. So all these features are there. And the obesity per se plus the GDM that she has developed, she has hypertension, makes her a candidate for an entity called as metabolic syndrome. Now we will see what metabolic syndrome is, but basically if we see the relation between OSA and metabolic syndrome, it has been clearly defined that as the OSA becomes more and more severe, right? If absence of OSA, about 18.6% have had metabolic syndrome in this particular clinical study. But as the OSA becomes more severe, like mild, moderate, severe, the number of cases of metabolic syndrome increased from 18 to 57. And when the other way around 60% of individuals who are already diagnosed as metabolic syndrome experience to have moderate to severe OSA. So there is a good link between these two entities which has been already diagnosed. A prospective cohort study also has been found that around 17% of OSA patients, if they are diagnosed to have OSA today, but as they are lean and thin, for example, they don't have typical features of metabolic syndrome, but they over a period of 6 years will develop metabolic syndrome. So what is this metabolic syndrome? It was first labeled or defined by World Health Organization in 1998. It includes central obesity. So mark the point that overall obesity is not very important. The central obesity, the waist circumference in men more than or equal or more than 102 centimeters, in women more than equal to 88 centimeters. Elevated lipids, that is triglyceride more than 150, low HDL in men less than 40, women less than 50. Elevated blood pressure, systolic BP more than equal to 130 or diastolic more than equal to 85, and elevated fasting sugar. So all these things, if they are put together, then it defines metabolic syndrome. So why metabolic syndrome is significant? We all know that it doubles the risk of cardiovascular risk and also increases the risk of having type 2 diabetes. So cardiovascular risk means everything, IHD, the stroke, everything increases. So knowing metabolic syndrome and diagnosing it is important, and as we have seen in the previous slide that there is a strong link between OSA and metabolic syndrome. That's why how both are connected, that is important, and treating OSA obviously becomes important, because without treating OSA effectively the metabolic syndrome will not be controlled. But as the chicken and egg situation is there, it may be the other way around. The metabolic syndrome also can cause obesity. So how that happens, that we'll see. Before we go to that, just to reiterate that how common OSA is. This is a paper which has come in 2025. Similar journal that reported in 2023 also some data which was shared by Dr. Shivani, but this 2025, about 1/3 of Indian population suffers from OSA. So it's a very common disease. What I'm trying to impress upon you is that it's a very common disease. So that has to be kept in mind. And if we see these numbers, that how often OSA is seen in patients with various metabolic disorders, this will further prove my point that if the metabolic disorder is there, then the prevalence of OSA further increases. So the earlier slide showed that how common it is in the general population. But here if we take the selected patient, if a patient has come to us with hypertension, the chance of OSA is 50%. If the patient is now labeled as resistant hypertension, chance of OSA is 80%. In a diabetic, chance of OSA is 70 to 85%. A central obesity patient, 50 to 80%. Hyperlipidemia, 60%. MASLD, fatty liver, 60 to 90%. Hypothyroid, 74%. PCOS, 30 to 40%. Male hypogonadism, 30 to 50%. Hyperuricemia, 40 to 75%. Even in osteoporosis, OSA is very high. Why I am putting this forward to you, that all these metabolic diseases, if you have a patient coming to us, the patient generally don't come to us with a diagnosis of OSA. They will not come and tell us that I am having OSA, or they will not come and upfront tell us that I am snoring, or the bed partner also not bringing their husbands or the others are not for snoring. They will come to us for one of these disorders. And when they come to us with one of these disorders, it is our job as doctors to suspect OSA in them. And the commonality that we are seeing again by looking at this slide, and it further goes to prove that there is a strong link between OSA and metabolic syndrome. Because in general population, the incidence was only 30%. Here, the incidence has significantly gone up. So that's why we have to suspect OSA in all patients coming to us with metabolic disorders. So it is a bidirectional link. The chicken here is the poor sleep quality or the poor sleep duration. The egg is the metabolic disease. But truly speaking, it is actually not one. What comes first we don't know, but it is the feedback loop. Both are feeding each other. The key facts, if you have to note here, is that if the sleep duration is less than 6 hours, the obesity risk increases by 45%. So if the sleep is not adequate or not good, the sleep obesity chance for that is metabolic syndrome increases. And other way around, there is 10% increase in the baseline body weight is associated with this. If that happens, if the body weight increases by 10%, that you tend to become obese, your obviously chances of developing OSA increases by 6-fold. So both are feeding each other. So how OSA causes obesity? Around 60% OSA patients are obese. OSA, as we have seen earlier, it disrupts the endocrine system by causing sleep fragmentation and hypoxia. OSA increases the leptin, that is the fullness hormone, and it decreases the leptin, that is the fullness hormone, and increases the ghrelin, that is the hunger hormone. So this hormonal balance on your hunger mechanism is disturbed, and there is a tendency to overeat. OSA reduces insulin sensitivity, causing storage of fat. The sleep deprivation reduces BMR, pushing the body in conservative mode. So OSA is basically perceived by body as a threat. Every night you are getting choked, your sleep quality is not good. And when there is threat, there is a tendency to conserve. You want to save more. So body will save more, will eat more, will store more fat, everything. The excessive daytime sleepiness causes fatigue, reducing physical activity, and also the small activities that we do, the simple walking, just going to open a door. These are activities also which cause non-exercise activity thermogenesis. That also goes down. So generally, a person with sleep apnea becomes sluggish, he becomes alsi. वो एक जगह पे बैठा रहेगा, हिलेगा डुलेगा. So that kind of a thing, they will put on weight. The repeated apnea triggers sympathetic nervous system, causing excessive cortisol release, and this actually tends to cause the Cushingoid feature that is typical of the central obesity, the excess cortisol. There are studies showing that analysis of intra-abdominal fat areas in obese patients with and without OSA was done, and it revealed that OSA tends to have markedly larger visceral fat areas compared to those without it. And visceral fat measurements, when they are done with using the technique, obviously it was seen to be more predictive of OSA than the only BMI. So the central obesity obviously is significant. Now, as we are talking the other way around scenario, this is bidirectional. So obesity also can cause OSA. That how OSA causes obesity, the obesity can feed back to OSA. So it is the main risk factor for OSA. 50 to 60% obese individuals with metabolic syndrome and OSA we already seen. Now what happens is that compared to fat deposition in other areas where there is central obesity, it is more fat accumulation happens around the neck, which exacerbates the upper airway obstruction during sleep by causing tongue-based hypertrophy and lateral pharyngeal wall crowding. So there is excess fat inside the throat also. When there is fat around the body, especially around the waist, then the neck will become larger and there is internal fat also. If the neck size is more than 43 centimeters in men and 40 centimeters in women, it definitely correlates with high incidence of OSA. There are some statistics about how obesity OSA further correlates. A 4-year study has shown that for every 10% increase in body weight, apnea-hypopnea index increases by 32%. Incidence of moderate to severe OSA increases by 6-fold. And conversely, if we lose 10% weight, the AHI decreases by 26%. So it obviously shows the importance of losing weight. Now, just one interesting question that you may say that only 60% obese people are having OSA. But this question we never asked, that why the remaining 40% do not have. This is something which we should ponder upon, because then in that case, every obese person should have had OSA, isn't it? So if that is not the case, and this question, when you think, it can give us some answers to other the endotypes or phenotypes of OSA which are there, which may also be responsible for causing the sleep apnea. So people who are otherwise obese but still not having OSA may be having some other advantages, like their pharyngeal lumen size may be naturally big, their body structure or the skull anatomy is such that they have naturally better throat area under the space inside, that is an airway that we talk about. The high lung volume also of such people, some people who have high lung volume, their tracheas are well pulled back the lung down, and then there is less of crowding happening in the throat. High upper airway neuromuscular compensation. So we were talking about this hypoglossal nerve stimulation. What is hypoglossal nerve stimulation doing? After all, it is allowing the muscles in the throat to become taut so that the area is opened up. The dilator muscles are acting. But some people are blessed to have that kind of a feature. Even high arousal threshold without getting micro arousal. So they are able to pick up that there is an apnea happening or likely to happen, but the brain takes a corrective action without awakening the person. And low loop gain, these are some endotypes of sleep apnea that also are important, how the patients actually develop sleep apnea. Not everybody has to have an anatomical cause, there may be the other issues also. So there are some people who are naturally blessed to have this kind of feature, and that's why some obese patients may not get sleep apnea. So this is one point that I wanted to share. Now let me just take you through a list of other correlation with OSA, that is hypertension. A study in 2000, this has appeared in a very reputed journal, that is NEJM. It has shown a strong independent dose-response relationship between OSA and hypertension. But still, we are not investigating our hypertensions upfront for OSA. It has been already shown so commonly. So my purpose of today's main talk is that how we can pick up these cases from the common populations, which can go to a general practitioner, can go to a consulting physician, or can go to a cardiologist, can go to a neurologist, where they should suspect the possibility of OSA and investigate. So hypertension, how OSA causes hypertension, let me just take you through that. The data has already shown that there is a strong link between the two. The intermittent hypoxia, or a prominent feature of OSA, can trigger spikes in BP, and excessive activity of the sympathetic nervous system is responsible for that. Also, there is a drop in the nocturnal dipping that is commonly seen, and may have consistently elevated BP even during the day, because the increase in the sympathetic drive, which has happened at the night time because of the choking and the intermittent hypoxia, that sympathetic drive may persist throughout the day, and such person who initially became a non-dipper at night later on becomes a persistent hypertensive throughout the day also. That is how the OSA can lead to making a person hypertensive. Here I would like to draw your attention to a person with hypertension where we are suspecting a secondary hypertension. We will investigate them and look for hypothyroidism, renovascular cause, renal parenchymal cause, or even primary aldosteronism. But when we see the data, the incidence is relatively so less compared to OSA. So OSA can be responsible for hypertension in the case of secondary hypertension, so-called, in almost to the tune of 50%, whereas all these other causes are relatively rare, but in a common investigation profile of a hypertensive patient, especially a young hypertensive patient, when we are doubting there are maybe some other causes responsible, we may not order a sleep study, but we end up ordering all the remaining tests of renal arterial Doppler and even renal aldosterone levels, which I'm not saying are not important, but along with that we should order a sleep study also, unless without which we will not pick up the sleep apnea. Even hypertension feeds back into sleep. That chicken and egg phenomena goes on. So even people with per se hypertension also, they have a tendency of the sleep getting affected. So that feedback loop goes on. Because patient with hypertension may have underlying anxiety, depression as a comorbid condition, they may disturb sleep. The headache and angina, dyspnea occurring because of elevated BP can also disturb sleep. And there are side effects of the hypertensive medicines also, like beta blockers or calcium channel blockers, which may also cause disturbance in sleep. And especially hypertension with CKD, there is something called as melatonin acrophase, that is the circadian variation of melatonin is disturbed, and that causes non-dipping of the BP at night. The melatonin which is supposed to be increased at night, that doesn't happen in the patient with hypertension CKD. So the level of renin-angiotensin will go up, and the reactive oxygen species also increase, the inflammation increases, and it feeds back into it. So people, once they are into that vicious cycle, each one feeds each other and the complication increase. Similarly, the relation between diabetes and OSA is a very well-known phenomenon, though we are not investigating all our diabetics with possibility of OSA. How OSA causes diabetes? OSA causes intermittent hypoxemia that leads to beta cell dysfunction and insulin resistance. Hypoxia also causes increase in cortisol, which will increase the glucose level. It increases sympathetic excitation, and that will cause insulin resistance. And the inflammatory cytokines are increased, which will also cause insulin resistance. So in all possible ways, OSA will lead to worsening of sugar control and will lead to diabetes. Similarly, diabetic patients also are at a risk of developing sleep disturbance. Again, the feedback loop that I was explaining. That in diabetes, the common problem is nocturia, nocturnal fluctuation in blood glucose, peripheral neuropathy causing pains, depression, periodic actions of the limb, and RLS. These are common features of diabetes, and that can exacerbate the insomnia. So once you are in that trap, it keeps on feeding each other. OSA can cause hyperlipidemia also. There is adipose tissue hypolysis, adipose tissue lipolysis, which can happen because of intermittent hypoxia of OSA, the SNS activation, and there is also hepatic de novo lipogenesis, impaired lipid clearance, and the inflammatory and oxidative stress causes more lipid peroxidation of LDL, which causes oxidized LDL, which is a highly atherogenic species. So the hyperlipidemia also can be caused by OSA by almost similar mechanism. And if you have to summarize into a slide here, which is almost the same what we have talked about, is that your obstructive sleep apnea has a bidirectional relationship with obesity. And once you're obese, there is excessive sympathetic nervous activity, RAS is activated, all the inflammatory cytokines are activated, adipose tissue also causes it gets inflamed, lipolysis, glucose uptake is also reduced, and then there is metabolic syndrome. So I think we have adequately proven how both are interrelated now, that both are feeding each other. This is one thing I want to draw your attention to, is that sleeping enough is important, not less, not more. So the short sleep as well as long sleep both were connected with metabolic syndrome, and obesity, hypertension, hyperlipidemia all can be increased because of lesser duration of sleep as well as longer duration. There was one question somebody asked, that if one sleeps only for 4 hours, how does it work? But maybe it is that particular time they are now able to sustain, but if you watch them over a period of time, because this is one study which is almost involving 3 lakh participants from China, it has shown that all these, if there is less duration of sleep also, over a period of time, they end up having metabolic syndrome. At that, for those particular 2 years, that when they are studying they may not have problem, but as they go ahead they will obviously have a problem in life. So it is better to aim for an ideal duration of sleep in most of the people as we live. But unfortunately the current era is such that we are all sleep deprived for some of the other reasons, like even demanding home life at home. There are places where the water supply from the municipal corporation comes at 4 o'clock in the morning. They have to get up at night to fill water. Mosquitoes are always there. There's a lot of noise around. So there are various reasons. There are work demand is there. People have to work in shifts. Then this delayed sleep phase syndrome, especially seen in young children who will, or young adults who will sleep at 2 o'clock in the morning, get up at 11 o'clock. So all these things there. But to top all is always the obstructive sleep apnea, for which we are all discussing here. There is a role of circadian rhythm which also plays a role, because as we said, if you eat late at night, there is going to be a problem, because every organ has its own clock, and if there is circadian misalignment, and if we eat at a biologically incorrect time, there is going to be dyssynchrony, and the pancreas will not respond in the same manner which will otherwise happen. So studies have shown that shift workers, when they are eating the same amount of calorie but eating at a biologically inappropriate time, they end up having more excursion of postprandial glucose compared to those who are eating at the right time. So the new era in which we all are living, the generation that works throughout the day and night, we are all unfortunate because of the scientific revolution, I would say, or the demands of the current lifestyle that we are in. We have to work at odd hours and we have to finally end up having these problems. Is it an indication for time up or is it something else? Time up? Okay, I'll find out quickly. So there is a link between genetics and OSA also that we have to keep in mind. It's not only a structural problem, but that's why we see that there is a strong link between the family members. So when patients come to me, I ask them history for OSA in their parents, in their children, siblings, and they say हमारे घर में तो सब लोग कराटे लेते हैं. So that is considered as a very common familial trait, but actually all of them maybe are at risk of having OSA. So that is important to remember. And they have some craniofacial structure, body fat distribution, or ventilatory control issues. So these may be the factors which make them prone. But we should remember, as family, they suffer from metabolic syndrome. All of them have a big paunch and they are obese. So that familial thing also we should keep in mind. As our case started with pregnancy, so that's what I want to draw your attention to. That pregnancy-related OSA can cause multiple problems in a mother, and can cause preeclampsia, can cause hypertension, that we talked of, pulmonary edema, and then the child also suffers because of prematurity and respiratory distress, especially they are born with lesser weight. So that is an important thing we should remember, and that's how we can correlate how a mother who is sleep apneic, if the baby suffers in utero because of the hypoxia that is happening to her, and it can lead to a small early birth, that is a low birth weight baby, and such low birth weight babies when they are overfed during their lifetime, they end up getting more metabolic syndrome. So where the whole thing starts, it may be starting with a mother who is been obese and she has never been suspected to have OSA. Our patient that I have just now mentioned was a lady who was already snoring, but she was already 72 kilos, was undergoing IVF treatment, but was never asked for sleep, about the sleep history, and was never investigated for OSA. She finally managed to conceive with the IVF treatment, and now landed up with bigger trouble because now she had developed hypertension. The baby is at risk, and such baby, if she finally even manages to deliver at 32 weeks, will be a small size baby, and that baby will somehow grow ahead, but that baby also may be overfed during his or her lifestyle and will become obese and will have OSA. So that feeding mechanism goes on and on. It's a continuously ongoing process. There is a huge association of diseases with OSA. Just wanted to list few, but then maybe the time may be not adequate. But if some 5 minutes are permitted, I will just take you through that list. Erectile dysfunction, then there is osteoporosis, fatty liver, glaucoma, and there are infertilities, then obstructive vertigo, hypertensive disorders, so polycystic ovary. So many of conditions are connected to OSA, and we have to suspect OSA. In brain, Parkinson's, stammering, substance abuse, attention deficit. In ear, it may be eyes, macular degeneration. I already talked about glaucoma, hearing loss, tinnitus, lung, asthma, COPD, pulmonary fibrosis. GERD is connected with sleep disorder, IBS, IBD, peptic ulcer. Kidney, you have nephrocalcinosis, nocturia. Reproductive, we already talked, infertility, loss of libido. Bone joint, accidents at work, frozen shoulder. All these have, there are good papers. I have not brought reference for every of these, but good papers, acne, bruxism, periodontitis, TM joint pain, infection proneness, cancer, RA, SLE, you name it and it is connected. So there are all variety of gamut of people who are moving around us and they are actually having OSA and we are not suspecting. Management wise, MAD is useful but will not solve the problem. PAP is useful but unless we treat there with, we try to reverse the metabolic disorder by weight loss, it will not work. So only PAP therapy will not be effective. Patient will become non-tolerant to the PAP also. So that's why it has to be a very holistic treatment where we focus on weight management, also physical activity. Exercise is important, walking, climbing, trekking, cycling, dancing, and yoga, meditation, chanting. All these are very important things. Myofunctional exercises to improve your tongue strength as well as and even the incentive, the inspirative muscle training with incentive thyrometry. These are all important for improving the strength of your dilator muscles and everything. So without which, so it's not only PAP. You have to go beyond PAP and do all these things. Weight plan, diet plan is important. You have to have time restricted eating. And obviously pharmacotherapy with tirzepatide is important, especially for obese people. Bariatric surgery also has a role, and there are it has been shown bariatric surgery is most effective, but other therapy like GLP-1 analogs are also important. And sleep hygiene, with this word has been repeatedly spoken about. 7 to 8 hours of sleep, maintaining regular bedtime, keeping bedroom dark and quiet, not to nap during the hour, no alcohol, it worsens OSA, avoid caffeinated beverage after 12 o'clock, not to smoke before bedtime, do not exercise 3 hours before bedtime, use bedroom only for sleeping and sexual activity, avoid mental stimulation activity before sleep, and if you are unable to sleep, get out of the bed and read book or light music, but don't watch a screen. So all these factors become important. Maintenance of PAP device is also very important. The filter cleaning and all that, for which the doctor has to advise the patient. So in this patient, I would say, as he is an OSA patient, as we have all agreed, only giving antihypertensive for this patient of pregnancy apprehension will not be adequate. We should offer CPAP to this patient, which is not a common trend that I am seeing still with the gynec obstetricians, and we should extend our talks to other specialty also. I don't know whether any gynec obstetrician is attending this seminar today, but it is important that all specialties, like even only one cardiologist is senior, our Dr. Sangiri sir is here. So conclusion of this talk is that chicken and egg debate proves that the sleep and metabolism, two sides of the same coin. We must stop viewing sleep as luxury and start viewing it as a clinically validated metabolic intervention. We can fix sleep and the metabolism will follow, and if we stabilize metabolism, the sleep deepens. The doctors have to take more and more interest in promoting sleep for all people. Current trend indicates that there is critical importance between sleep and metabolic syndrome. Routine sleep history, this was one paper that we wrote in Medical Clinics of North America very recently, and where we stressed the importance of taking routine sleep history. Like, आपकी नींद कैसी है? That should be a question that every doctor should ask. All systemic conditions have a link, so we have to address that. And doctors should need to be themselves aware, and we should investigate patients when they come to us for hypertension, diabetes, hyperlipidemia, ISD. When they come to us with these, like a fatty liver patient going to a gastroenterologist, the gastroenterologist should upfront ask for sleep history and do a sleep study. If that is not happening, it is of not use, or only a chest physician, or they may not be able to help them. So lifestyle modification is important, PAP devices are important, but counseling and ongoing medical help is required. And OSA, I feel, should become a part of national program on non-communicable diseases. That is what our government India is running. And such type of posters should be around to make people aware that snoring is an important symptom of a disease called OSA, which has such wide repercussions on your health, without which we will not be able to take this medical knowledge to the grassroots level. Thank you very much for sharing slightly over.